And recently, our health system celebrated a milestone. We participated in our largest living kidney transplant chain that started last June and ended in December. The chain saved 12 lives, involved 24 surgeries across 8 states. You might ask, how is that possible and how do you do that? We're going to show you the science. We have an impressive panel joining us here in the studio today. Dr. Diane Sibrick, Medical Director of Kidney and a Professor of Nephrology and Hypertension at the University of Kansas Health System. Jamie Bartley, Director of Nursing here at the Center for Transplantation, and Samantha Brenner, one of our living donor nurse coordinators. Thank you all for being here.
Yeah, glad to be here.
Good morning.
And welcome to our guests joining us virtually. Dr. Michael Reese is the transplant surgeon and CEO of APKD, the Alliance for Paired Kidney Donation. Krista Sweeney is the Director of Transplant Services at APKD. And last but not least, James Cochran, the star of the show, who made the decision to offer up his spare kidney to anyone who might need it. You could say James is definitely the most important person in this story today, because without people like James, there would be no kidney chains, and this video explains why.
Counselor James Cochran spends his days helping his clients find their purpose. But it was during his downtime one day when he found his.
My first awareness of it was through a podcast. It's called Stuff You Should Know. They had one on kidney donation and talked about what it entailed.
Little did James know that scrolling the internet for more information on organ donation would ultimately lead to him helping save the lives of 12 strangers.
I have the chance to make a choice that will make the world a better place, that costs me something that I am prepared to give and I have the privilege to give.
James started what's considered in the transplant world a kidney chain. It takes someone like James, a perfectly healthy person stepping forward out of nowhere, wanting to donate a kidney, setting in motion a chain of kidney transplants, in this case involving 24 people across 8 states. 2 of those transplants happened here at the University of Kansas Health System's Center for Transplantation. James's kidney was taken out here and sent out of state. He is considered the altruistic donor in the chain because it was his kind act that started it all.
It was an opportunity to really honor the value that every life matters, even if it's not a life that I'm aware of.
James doesn't think of himself as altruistic. He admits he got something out of it too.
I feel a measure of satisfaction. I feel a measure of pride. I can say that I have been able to do something that not everybody has the chance to do.
He says in researching the role of kidney donor, he found out it's just who he is.
We all are connected through this humanness that we possess. It always felt very aligned with the kind of person that I want to be and the way that I want to live in the world.
A world where we're linked together in some way, like the chain James helped create.
James, welcome to the show. In full disclosure, I may have been the surgeon that took your kidney out. You might remember that. But I really want to thank you for your willingness to donate. You wound up helping 12 people, not just one. But how do you feel about your decision now to spark this chain?
Great, I guess. It's occurred to me. We did. I was in for the morning medical update a couple of weeks ago, and there were 24 surgeries, including 11 other donors. I'm really excited to hear folks talk a little bit about how the chain works and how the those sort of matching algorithms and all that stuff come together, because I increasingly feel like I was just one part of this puzzle, and just really grateful to be able to be a part of it.
Yeah, you were the first match to start that puzzle being put together, absolutely. And we'll talk a little bit later with the team to help with that. So your surgery was back in June of 2024. How do you feel today? Is this how you expected you would feel physically and emotionally?
I feel great. I'm sort of just, steadily increasing in terms of bringing my energy levels back up to pre-surgery levels. I think I anticipated that it would increasingly feel like something that I did one time, and that's, I think increasingly how it feels. Like the past month has been the most I've paid attention to it, just with a couple of interviews with the team here. So yeah, it's just in the grand scheme of things, it is I feel like a relatively low impact thing on my life.
So studies have proven that living donation has many benefits over deceased donation. A living donor increases the lifespan of the recipient by about 10 years. Recipients enjoy greatly improved health and quality of life. Living donation also shortens the waitlist time for recipients, and a living donor actually offers better outcomes on that donation. Dr. Sibrick, expand more about that last point, better outcomes. Mm-hmm. I can tell you a deceased kidney doesn't always start working immediately, but whereas a living kidney tends to kick in right away. What's the impact that has on that patient, and when do we start waiting for that kidney to start working post-transplant?
So, the patients that get deceased donors it's pretty frustrating. A lot of these people have waited years to get a kidney transplant, and then they get a deceased donor and it doesn't function right away, so there's some frustration and disappointment waiting for that kidney to kick in. Mm-hmm.
So from your perspective, what are other medical benefits of a living kidney or deceased donor kidney?
Well, when I evaluate kidney transplant recipients, I always tell them I wish everybody could get a living donor kidney. They work right away, they function better, they last longer, they even have less rejection than a deceased donor kidney transplant. In addition, living donation can provide or have an avenue where people can actually avoid dialysis altogether, because you can get a living donor kidney transplant before even starting dialysis.
Mm-hmm. So on average, a living donor kidney compared to a deceased donor kidney, how much longer do they last?
Approximately about 10 years longer, but I had a patient one time who got a kidney from his father, and he had his kidney for 38 years, and it was still going. So
yeah, pretty incredible.
Mm-hmm.
So there are more than 100,000 people on the national transplant wait list, of which 92,000 are waiting for a kidney. That's a vast majority of people who need an organ. Jamie, you work with our patients. What are some of the leading drivers or reasons patients need a kidney?
Sure. The leading causes of kidney disease are diabetes and hypertension. And I think if we looked within our circles of those we know and care about, diabetes and hypertension impacts all of us, and we all have someone we would know that would be at risk for kidney disease. And moreover, like 1 in 7 have kidney disease, and chronic kidney disease can lead to kidney failure. So there are 37 million Americans in our country that have kidney disease, with like over 800,000 with kidney failure. So when you face kidney failure, your treatment options you're looking at are really dialysis and transplant. And so that you can see the staggering numbers of those who are waiting for a kidney transplant.
Yeah, these patients are sick, right? They are toward the end of the rope, right?
Yeah, absolutely. I think what was kind of remarkable to me is we are more familiar with hearing about breast cancer or prostate cancer, and the mortality associated to kidney disease is more than breast cancer or prostate cancer, and it's the 8th leading cause of death. So for those that qualify to be on the wait list, 1 in 12 people die without even receiving that kidney transplant. So stories like people like James who step forward, they truly, truly save lives. Because, for example, at our health system just this year in 2025, we've listed 82 new people on our transplant wait list. And we've worked so hard to transplant as many as we can, but we've only done 44 transplants. And so each and every month we're just, kind of chasing that carrot to try and save more lives. And we really need people like James.
Yeah, that's just in the first quarter, right? So that's an average of listing 1 a day almost.
Yeah.
So that's pretty good. So some of these patients have a willing donor, but they don't match. They are considered incompatible. To donate a kidney, you must match the recipient's blood and tissue. The donor organ needs to be compatible in size as well to the recipient. Age is also a consideration, as living donor kidney extends the recipient's life by about 20 years. Younger, healthier kidneys need to be matched to younger recipients. We also look at graft survival, how long a donor kidney will function for its new recipient. The Alliance for Paired Kidney Donation helps navigate the matching process using a Nobel Prize-winning algorithm to find a match for incompatible pairs. Dr. Reese, can you explain at a high level how this works?
I started being a transplant surgeon after all of my training. Do you hear me now, Dr.
We
Kumar?
hear you. Yes, Dr.
Okay,
Reese,
great.
Thanks.
When I started my career in 1999, if a patient came to my clinic and said they had a living donor and we found out that they had the wrong blood type or they didn't match, my answer was, I'm so sorry. There's the door. You're going to have to wait for a deceased donor kidney. And as we heard from Dr. Seabrick, that wait across the United States is 3 to 5 years. So when I heard about the idea of kidney paired donation, it had been done once or twice. It was I heard about it from somebody who'd done it in the Washington, D.C. area. And I came home to my home transplant center here in Toledo and tried to put this together. But it's very complicated to try to put together all the matches. So my dad, who's a computer program, actually helped me write a piece of software that let transplant centers work over the internet. And that was a very different thing back in the year 2000, so that transplant centers could put their pairs data in, and we could find out, for example, Dr. Kumar, let's say you wanted to give your wife a kidney and I wanted to give my wife a kidney. Let's say that I have the wrong blood type for my wife, but let's say you and your wife have had children. And one of the interesting things about having children for women is that when the baby is inside of them, they can make antibodies against the part of the baby that came from the father. Antibodies, while they don't attack the child, they do attack a future kidney. So one of the ways paired donation really helps is it helps women who are not able to receive kidneys because of pregnancy more frequently than men receive a kidney. So essentially what happens is, again, let's say you want to give your wife a kidney, I want to give my wife a kidney, but we're not able to. Paired donation allows me to give your wife a kidney and you to give my wife a kidney so that we could do a swap. But let's say you're a really nice guy and I'm not such a great guy. And on day one, you give my wife a kidney. And on day two, I say, my wife got a kidney, thanks. And your wife never gets a kidney. So that would be really bad because your wife didn't get the promised kidney. But it would also, it would make it so that she lost you as her person who was willing to give a kidney so she could receive one. So until 2004 or 5, we never did that. We always did these transplants at the same time. And it was about that time that I met Alvin Roth, who's a Nobel Prize winner, who suggested that if somebody wonderful like James came along, who said, I just want to give my kidney to help somebody, that he could give his kidney to my wife. And then if something bad happened and I chose not to do this or I wasn't able to do this, you would still be there to help your wife. We could put you back into the pool and find an alternative match. And that beautiful idea has now gone on to help 20,000 people receive a kidney transplant.
Yeah, those are just incredible numbers. And thank you for explaining. The simplest of this is the paired donation, just the swap. But then it becomes so complicated when you talk about these growing chains. So, Krista, can you help us understand, how does finding a match for one person grow into a chain?
Yeah, sure. So what we do is the algorithm helps us with determining the quality match, the best match. Age, the HLA, the proteins that are essential for kidney exchange. And so once we do that, it takes almost an orchestra. People have to come together. We get on these planning calls and we do it piece by piece. So, James started this chain and the algorithm found the next 3 links. So James gave to a recipient who had a participating donor willing to donate, and that donor, the system found the next recipient. And so we kind of did it in chunks. And what's beautiful about this is the coordinators get on, and there's a lot of work done on the coordinating level. They have to look at a donor that isn't their donor, their medical record, their CT images. They go to committee, that gets approved, and then we come together and start talking about things like, when are we going to send a blood kit? What is an OR day? All of those pieces that have to come together between 2 different centers. And so we do something called bridge donation and advanced donation. So a bridge donor is someone who is their recipient already received, and they've given a promise to pay it forward multiple weeks later. And that is essential because a lot of the pairs that enter into paired exchange are husband and wife or parents, and maybe they are one another's support person. So that gives them time to heal and support that other person before donating. That did occur in James's chain, as well as we had a couple of advanced donations that occurred as well. So that is when a donor says, now's a good time for me to donate, and I trust the next person is going to pay it forward. So I'm going to go ahead and donate, and my recipient, my loved one, is going to receive their transplant a little bit later. And so we chunk these, and the algorithm in the system then, as these pairs are entered, we find the next chunk and the next chunk until we simply cannot find another person that matches the next donor. And then we pay it back to a wait list. So James, in James's situation here, he donated, and then we created this beautiful chain, and it ended back at Kansas in his community with a wait list recipient. So that's the short end of it.
No. Didn't sound so short, so easy. But thank you for bringing us through that. We're going to meet one of those living donor coordinators in just a minute here that did a lot of that work and puts up my schedule a lot for many years. So you mentioned James, Krista. He's been on the top of the show. He's what we call an altruistic donor, and he sparked this chain. Why is someone like him so critical for these types of matches?
Oh, James, you're essential because you are not tied to a specific recipient. And so your kidney can really just go to anyone that you match to. And so the algorithm looks at things like sensitivity. And so it prioritizes people that are highly sensitized. And you had several people in your chain that were also very difficult to match. And so when you're an altruistic donor, you are not tied to anyone specifically. So that gives us a lot of opportunity for matching in the system.
Dr. Reese, it must be incredibly rewarding. You mentioned a few minutes ago that 20,000 kidneys, 20,000 lives saved. Please tell us a little bit more about how you feel about that.
Well, all of us doctors become doctors so we can help save people's lives. And I've personally done about 1,000 kidney transplants. But academic medicine allows doctors to not only do things directly for people, but to come up and to create the future. And so the fact that now we have 20,000 kidney transplants is really rewarding to me. But as Krista explained, it takes a team and a symphony, and there's lots of different players in this. And I'm so grateful to the Nobel Prize winner. I'm grateful for your team at Kansas and our 50 transplant centers across the United States. But it really starts with people like James. And what I think the thing that's most rewarding about this is we came up with a way to multiply his altruism. When he gave, let's say, go back to the story of you want to give your wife a kidney, I want to give my wife a kidney. When he gives your wife a kidney, you weren't really quite as altruistic as James because you weren't willing to donate unless your wife received one. But as soon as James gives your wife a kidney, you become like James. You're willing to help anybody. And that gives us the flexibility to help the next best person in line when there are many people. And having that flexibility is what allows us to do this, as Krista explained, immediately or to give it time. And the combination of time and this beautiful flexibility of only having to go in one direction and not having to do the reciprocal exchange of you and I swapping is what's really amplified this. And it gives me a lot of joy that James' altruism was actually passed to 12 different donors, and 12 people became as beautiful as he is. They were already beautiful people. They were willing to do something beautiful, but they became even more beautiful because of the amazing gift that James gave.
Yeah. Thanks, Dr. Reese. And also thankful for your dad with the initial programming, right? Samantha, you're a living donor coordinator and you work with James. What goes into coordinating and how many patients are you handling at a time?
Oh, a lot goes into the coordination. First, James has to start the process. He has to come in, be evaluated, seen by the whole team, get approved to donate. And then with an altruistic donor, we're always looking at, how can we do the most good? And in James's case, he was an O, which is wonderful. And we only had a couple of people at KU that were not compatible. So we might have been able to do like 2 transplants if we just kept James at KU. But we discussed entering him into Paired Alliance, where he could probably do more good and make more transplants happen. And it just so happened that he could help a lot of people with his donation. And then as far as my number of patients, well, anyone that has called to donate, has donated, wants to donate, the list is probably hundreds of people really in different stages.
Well, thanks for what you do to keep us going straight on this. I appreciate it. So, Krista, we heard a little bit earlier from Dr. Reese. He mentioned a little bit about a break in a chain. What happens when that occurs?
So when chains break, and James, actually, your chain did fall apart a couple of times. And basically what we do is we take that next link and we put it back into the system and let that algorithm do its job. And we start fresh. So we'll, the next couple of links will, again, those coordinators will have to review the donor medical records, CT images, get a committee approval. Then we come back together and get on a planning call, discuss OR dates and cross-match kits, so the blood kits. James, I'm sure you had to draw multiple times, and we just keep going. You just plugging away. There is, it is can be frustrating, but also very satisfying. And when it's all done, all of our coordinators, we celebrate together and we check in on donors and recipients. And it really is a celebration at the end of every chain.
All right. Thank you. James, I want to switch over to you. A lot of people might want to donate, but worry about their work, their health. Are there any barriers that you experienced that made you think twice?
I mean, I think there were. I thought of probably more than twice over the course of the whole process, but the Alliance does a great job. They have resources to help recoup like lost wages. They've got, one of the questions that I got all the time was, well, what if someone you love needs a kidney, and there's this sort of family pledge that you can, participate in, so that if someone really close to me ends up needing a kidney, they have like a different kind of access to that process than they otherwise might. So I don't know. I think that there's no changing the fact that like it's gonna represent challenge. Like there's no removing all the barriers. At the end of the day, you're still having a major surgery. But I think that is the throughout the whole process. I think I just was very well assured by all the people involved that this is something that I'm capable of doing.
Krista, I'm sure that you all deal with tackling barriers like we do. How do you all in the Alliance tackle those barriers to donation?
We don't give up. We keep going. And, some of our barriers that we see in the system are folks with high PRAs. Some of the barriers are when you have an unsuspecting DSA and we have a cross match that we didn't anticipate come back positive. And what you have to do is you keep going. You think about the greater good and you put that aside. You utilize the algorithm that is designed to find quality matches, and we just keep going. And I think the other thing that we've seen now is an influx of compatible pairs joining the system. So pairs that actually do match, but they're looking for a better match. And that has opened up additional opportunities for our harder to match folks. And our pool is growing regularly to also help combat some of those barriers that we've seen in the past.
Dr. Reese, what work still needs to be done?
Oh, that's a great question. There's lots of things for us to do. Listening to James talk about our donor protection program, it's really important to us to take good care of people who want to donate a kidney and to protect them. And obviously, James can't donate again. He can only give one kidney. And if, God forbid, anybody in his family ever needs one, we've come up with a mechanism now to be able to make sure that we can say thank you to the person in his family that he would have given his kidney to, but instead gave it to someone else. Because remember, when he created a kidney, when he started this chain, it allowed us to be able to end the chain. And we have some flexibility in the future now to help James or somebody in his family if that's ever needed. And this beautiful algorithm that's been designed by Alvin Roth, the Nobel Prize winner, gives us that flexibility to think about new ways to try to help people in the future. And we're doing that through our donor protection program. I think a couple of other things that I'd like to see happen in the future. We're working right now to change the way we start chains. So James made this beautiful decision, but we have a lot of people. Most of the transplants we do in the United States, as Dr. Seabrook explained early on, come from people who've unfortunately died, and as their last act made the beautiful gift of giving their kidneys to try and help save somebody else's life. Right now, each of those kidneys helps one person. And when people like James used to give a kidney, their gift helped one person. So one of the things I'd like to do in the future is to have some deceased donor kidneys start a chain so that that kidney could turn into many kidney transplants, just like James' kidney has done. And I'm pleased to say that the Alliance for Paired Kidney Donation has partnered with the United States military to do just that. So some people are able to participate in something called the Military Share Program, where one of the two deceased donor kidneys from the person who's died can be given to the U.S. military. The U.S. military is now offering those kidneys with the consent of the Pentagon to start a chain. And when the chain comes to an end, we give it back a living donor kidney to somebody at Walter Reed. So the person who's died has not only helped many people, but has helped one of our active duty military people. So that's something I hope we can grow and expand. So far, we've done 14 of them, and we've helped about 40 people. So it's helping almost 3 people for every deceased donor kidney. The next thing I'd like to see is right now, every country does their own deceased donor program, their own living program. But the truth is, some people are so hard to match, they need a needle in the haystack, and making the pool of potential donors as big as possible would really help them. So I'd like to expand this so that different countries can work together. Imagine Switzerland, for example. They have 8 million people in their country. That's smaller than my state of Ohio's population. Imagine if all 50 states, Kansas worked by itself, Ohio worked by itself. We couldn't put together this beautiful exchange that went across many state boundaries. Now imagine expanding that so we could work across international boundaries and help even more people. That's something that we're building. The Alliance for Paired Kidney Donation is now in 15 countries around the world, and we're building the pathways to try to make some of those connections.
That's fantastic. Thanks for sharing that. Dr. Seabrook, in full transparency, you are an advisory board member for the Alliance for Paired Kidney Donation. Tell us why our health system works for the Alliance.
Oh, that's pretty simple. First of all, the Alliance is the original or the oldest program that pairs living donors with transplant recipients. In addition, what I find is attractive about the Alliance, it's actually run by a transplant physician, surgeon, Dr. Mike Rees, who ran it, developed it, and understands transplantation. I also like the idea of this donor pledge that Dr. Reeds as well as James alluded to, where they help with lost wages, transportation, the family donor pledge. I think that's also really key for this program.
Yeah.
And that's why we participate.
Yeah. Thanks for getting us involved.
Yeah.
We're here to answer your questions. Please send them in using the info on your screen. That includes the chat on YouTube or Facebook, or emailing the Medical News Network. So let's check in with Doc Hawk. We've been getting a lot of questions about measles. What are you seeing?
Yeah, so far right now around our community, and certainly at the health system, we have not seen any cases. We have great systems and processes in place that have been in place for over a decade to identify emerging, re-emerging infections, things of that nature. We have that in place. We have information going out to our providers and our clinics for anybody that thinks that they may have contact with a patient with that. So we have those processes in place. We've had some testing done on potential patients because of concerns, but no identified cases so far. Really, we are focusing on being prepared in case that does happen here at the health system and around our community. But we know that there are those cases in Southwest Kansas.
So I know that you're going to be updating some numbers here pretty soon with KDHE, but the number was 23 a week and a half ago in Kansas. Now those numbers are over 400 in Texas. Is that right?
Yeah, absolutely. And I would also say that along with us doing our processes here, we are working closely with KDHE as well. We are in communication with them several times a week. We know that KDHE should be reporting new numbers today. And as of right now, like you said, there are 23 cases for all of 2025. There was one case in January, one case in February. So in this new kind of cluster in Southwest Kansas, looks like we have about 21, but we are expecting new updated numbers today. And yes, just as you said, the numbers in Texas, West Texas and New Mexico are higher. We continue to see those grow. We should expect those to continue to grow. But that is in addition to other places around the United States as well. And I think it's a combination of factors. Number one, we are in a different place than we were before the pandemic. Certainly, I think we should state that in 2019, there were about 1,200 cases of measles in the United States. Again, the vast majority of these cases that we have been seeing in the United States since 2000, when measles was declared eliminated from the United States, are due to people who are having international travel and are unvaccinated. Again, in 2019, we had a large number of cases, but right now, we have currently surpassed our 2024 total for measles. And I think, again, it's a combination of factors. Number one, it is a decreased amount of vaccination coverage overall in the United States, especially since the pandemic. There is obviously a lot of misinformation that we are fighting against every day, Dr. Coomer, and there is that significant distrust of the medical establishment, government and public health entities as well. So we are all battling against that. But what we want to continue to say is that measles continues to be a disease of the unvaccinated. We have a very safe, very efficacious vaccine that's been used for 6 decades. It works. It will protect you. It will decrease the chance of any of these complications from that. And if we know that we have significantly lower vaccination rates right now, this is why we can see the explosion of cases, especially in those people that are unvaccinated.
Yeah, unfortunately, the word vaccine got politicized, which is unfortunate and kind of amazing to realize in early 2000 we had eradicated measles from the United States. Now it's back with a fervor, all because the majority of these patients, nearly all of them, that got measles were unvaccinated.
Yeah, I think you're right. And again, just like you said, nearly all of them. I think there are less than a handful of cases in the West Texas outbreak that were actually vaccinated. But it really is that group that is unvaccinated, especially when you are talking about those children who are 12 months or less, where there is not an indication for the vaccine, although you can get it at 6 months. Generally, vaccination starts at 12 months. But it's really a tragedy when it's these patients who are unable to make decisions for themselves and are at high risk of getting the disease and, of course, getting the complications. And some of these complications can last for years or even their whole lifetime. So I think it is important to understand that.
Thanks, Doc Hawk.
Yeah.
Jessica Lovell is watching for questions from our community. Jess?
Good morning, Dr. Coomer. Yeah, the first question is from Mary, and she just wants to know, how can we connect with the Alliance for Paired Kidney Donation? Just connect with them and find out more information about them.
Dr. Reese?
Well, you can connect with us by going to the internet and the web. We're at www.paired, PAIRED, so paired donation, but all one word, .org. And that's probably the easiest way to connect with us.
Next question is from Jeremy. He wants to know, as a donor, what kind of health or lifestyle choices increase your chances of your kidney being a good match or more successful, or is it mostly genetics and blood type?
Dr. Sibrick?
Yeah, sure. It's the latter. It's genetics and the blood type that really matter. All Americans should be eating healthy, exercising, low salt, low cholesterol. So, but it's really the genetics, the HLA matching, and the blood type that matter.
Lon has a question.
Dr. Kumar, do you mind if I just add a little to that?
Sure, absolutely.
So, I think one of the things that's important for the person who's asked this question is that the transplant community is very worried about donors. We want to make sure that everything goes great for them, and we invest a lot of time, energy, and money to make sure that this is safe. And it is very safe across the United States. It's now about only 1 in 10,000 people who die doing this, so we've made the operation very safe. But it's become safe because we put a lot of time and energy into making sure that people don't have any conditions that are going to prevent them from donating. So as Dr. Sibrick said, the matching is really about other factors, but it's also that we're really careful to protect donors to make sure that it's safe for them.
Lon has a question for Krista. If all kidney transplant centers participate in living kidney donation, and how unique is the Alliance?
So the Alliance is one of 3 registries in the country. And I think what sets us apart is our donor protections, as well as just our service that we provide. We're very transparent. We're very communicative with donors if they have any questions. And so we're always accessible and easy to work with. Dr. Reese, is there anything you'd like to add to that?
Well, one of the cool new things we're doing at the Alliance for Paired Kidney Donation is letting donors have a little bit of say when they don't have somebody specific they want to give to. So, for example, we talked about Dr. Kumar wanting to give to his wife, and of course he gets to make that choice. But when James came forward, he just said, here's my kidney, you guys made the choice. And we'd like to put on the middle, choosing the person. So we're starting a new program called Community-Directed Donation, in which James might come forward and say, just like with our partnership with the U.S. military, I want to help somebody who served our country through the military. And now James gets some say in how we do that. So we actually, through our special algorithm, can make it so that James's wish to help many people, but also to help somebody in the military, can happen somewhere through the chain or perhaps at the end of the chain.
Well, this has been a great discussion. Thank you so much to all of our guests. I want to get some final thoughts from our guests, and we'll start with the star of the show, James.
It feels strange being the star of the show, but I guess, I don't know, I'll part with the same thoughts that I parted with last time, which is that if you're seeing this and you're wondering, maybe I'll donate my kidney, I think just trust your future self that you can, with all these different professionals and resources, that you are capable of doing that challenging thing.
Krista?
I just want to say thank you to James and all of the donors that consider donation, because without donors, we have a lot of folks receiving deceased donor kidneys or on dialysis. So thank you, James.
Dr. Reese?
Likewise, James, I think it's awesome what you did. I love your final comment, and I would just say we're going to protect your present self and your future self. And the Alliance for Paired Kidney Donation and our participating centers like the University of Kansas would love to turn somebody else's gift into many transplants. Just like when you listened to that podcast and decided to go and do this, maybe somebody listening today will decide to save many lives, and we'd love to participate in doing that. Thanks again, James.
Thank you all. We'll head back to the studio to get some final thoughts. And Samantha?
Well, all of my patients are people like James, so thank you for letting me have a wonderful job with wonderful patients that are people like him that would save people's lives.
Jamie?
Thanks for having me, Dr. Coomer. I hope that anyone that's listening, like you, might connect with us either as a recipient or somebody on the wait list or somebody considering organ donation, and whether that's through signing your card at the DMV or calling us expressing your interest in living donation. I hope that this provides information and introduces you to a team of people that I get to work with every day, that we're just not going to give up. Those numbers are numbers, but they're real people. And we are here to help you and help them. And I hope this inspired, and James inspired, hope for those who are waiting. And it's our privilege to kind of get to take care of you. So if you need us, call us.
Great. Dr. Sibbert?
Yeah, the reason I did this program, I just wanted to increase awareness of living donation, and what James did is just so remarkable. And over the last 10 years, the amount of living donors that have come forward really hasn't changed. It's between 5,000 to 6,500, since 2014. So as James did, one person changed 12 lives, and if we can continue that trend, it would just be fantastic for a lot of people.
Yeah, thank you. My final thoughts are really, donors are the lifeblood of life for lots of people, and giving of themselves, whether it's living or deceased donation, please make that decision. Discuss this with your family. People need to know that, and it might inspire other people in your family as well as friends to do that, to save a life. So thank you all. Thank you everyone on the panel. Thanks for watching and listening. Remember, faith, hope, and science.